to this another edition of SkillsForMED free webinar. So coming to the webinar this week, it's a very practical oriented webinar. It's about effective urinary catheter care and urinary tract infection prevention. We're not going to talk about the technique of insertion. So it's more about how to maintain a catheter once you put the urinary catheter in to avoid complications and to avoid infections. So that is the agenda for this week's webinar. And so let's get into that. So what we're going to discuss this week is what precautions you have to take during insertion, what are the best practices for catheter maintenance and removal, and finally we'll touch upon the urinary catheter care bundle, which will prevent most of the complications. Now, let's first talk about inserting the urinary catheter. So the importance of urinary catheter in healthcare setting is because we need to follow evidence-based practices. Most of the time, what we do is just learn from seniors and we do this, whatever they have been doing. But what we need to do is to follow the best practices. And most importantly, as I already pointed out, is to prevent infections, that is catheter-associated urinary tract infection. And third is to ensure compliance in safety standards. And last but not the least is to improve patient comfort and recovery. So with this introduction, let's get into the actual problems at each phase of urinary catheter care. Now, what are the common problems? So it could be, the most important is the catheter-associated infection here. And there is feared or most tragic complication as urethral trauma and injury, blockage and obstruction of the urinary catheter, leakage around the catheter, incrustation and formation of the biofilm, patient discomfort, and psychological stress of having a catheter in situ. These are all common problems of urinary catheterization. Now, let us first look at what are the complications which can happen during insertion. One is urethral trauma. The second is incorrect catheter placement. And third is infections. So the early onset of CAUTI happens because you have not taken proper care during insertion of the catheter. So let's look at the causes of each one of these and how to prevent them. So the first is lack of aseptic technique. Urinary catheterization is actually done as a sterile procedure. So if you look at it, there are clean procedures and sterile procedures. Now, clean procedures is something like putting an IV peripheral catheter IV line. But when you put a central line or when you put a urinary catheter, it has to be done as a sterile procedure. But these are done at the bedside. Usually, sterile procedures are done in the operating theater. So there's everything is set up. But as when you do central line or when you do urinary catheterization, it is done at the bedside. And you have to actually adapt the bedside to all the practices that are done in the operating theater. And that is the challenge. And many times, people cut corners. They will just wear a glove, sterile glove, and put the gel on the glove, and then just put it like that casually. So this is one of the reasons where urinary catheterization happens during insertion. There is lack of aseptic technique. So inadequate hand hygiene. So you need to perform a proper hand hygiene, or at least use the hand rub, and up to the elbow, and do the 6 steps of hand hygiene and 5 movements. If your hand is not soiled, but if the hand is soiled, then you have to do a proper surgical scrub before you put a urinary catheter. The second is the use of non-sterile equipment. The gel may be just lying in the cupboard for months, and you will use that gel to put to lubricate the catheter. So even the lubricating catheter gel has to be sterile. So there is a concept called um, antiseptic non-touch technique, ANTT. So here, that is what I was telling. It classifies into clean procedures and sterile procedures. And there is a set of techniques for clean procedures and set of techniques for sterile procedures. Maybe we should do a separate webinar on ANTT, but we can't explain more than that. But basically, to just emphasize that urinary catheterization is a sterile procedure, and you need to take all the precautions that you're taking in an operating theater. Sterile gloves, sterile equipment, and no, the sterile field, what you create is known as the microcritical sterile field. So many, no, in an operating theater, the whole table and surrounding areas is critical. Whereas when you do a bedside procedure, you should make sure at least the area around the procedure, that is in the urinary catheterization, it is the where you're putting the catheter. In the male, it is the penis and surrounding area, and in the female, it is the vagina and the surrounding area. This needs to be clean, and that is known as the microcritical sterile environment. Even though no, the rest of the environment may not be sterile. The fourth problem is contamination of the sterile field. So you need to make sure that the urethral meatus is cleaned with an antiseptic. You can't just clean it with saline and put it, because you need to disinfect the area, and you allow all the disinfectant to dry before you actually put the catheter. And also, while doing the catheterization, there are several reasons why contamination can happen, and therefore it is better to screen yourself away from the other people and areas and do the catheterization. The second problem is you can use the wrong catheter type or size. So the urethral injury happens because you use the wrong type of catheter or the wrong size of catheter. So selecting an inappropriate catheter size or material is the cause, and you need to assess the patient needs. So general rule is use smaller catheters, 12 to 14 French. Okay, in a female, you need to use maybe 10 or 12. Pediatrics, much smaller than that. And most of the time, you'll be using a one-way catheter, and you can also use a three-way catheter if you're using irrigation. Okay, so that's about the catheter sizes. And there are several types of catheter. I think the most common catheter is the what we call as a Foley's catheter, which is made of latex. Which is made of latex, and it is then you have intermittent catheter, which is made of PVC. This is a bit stiffer, and is either used as an obtain a sample, or to just empty the bladder when the patient has got urinary retention, short-term urinary retention. And people who have an enlarged prostate, the stiff catheter actually can negotiate the narrowed urethra. And after a surgical procedure, just to empty the bladder, you can use the intermittent PVC catheter. Then you have long-term catheters, both Teflon coated catheters and also condom catheters, which can be used in males when they have long-term indications. So the catheter sizing, as I said, you choose the smallest catheter size. For adults, it is 12 to 4. For children, it is 6 to 10. If at all you're having a urological procedure, or a patient has got hematuria, then you go for a bigger size, 16 to 20, if there are a lot of clots in the bladder and you have to irrigate. So then you have to use a triple lumen catheter. So as you all know, that the catheter size refers to the circumference of the catheter, not the luminal diameter. When you say F, it means 1/3 of a millimeter. 1F is equivalent to 0.33 mm. So this is something to know about. So again, another reason for urethral injury is poor technique. Either you don't know how to handle the catheter, or it is lack of skill. I mean, it's not that you don't know. Maybe in a hurry, there is improper handling, or it is lack of skill. So you need to follow a standardized procedure. Whenever you do catheterization, it should be the same standardized procedure which you do. Position the patient correctly, because especially in the male, the urethra has several bends. and therefore you need to position the urethra, well. So as you can see in the picture, you can see while inserting the catheter, the penis is kept vertically so that the bends are straightened out. And then once you go in and and you feel a resistance, that means you're reaching the prostatic urethra. Then you put the penis horizontally and then insert the catheter. So this technique is very important, and you need to use a water-based lubricant. And you could actually put the catheter inside the urethra, but make sure that you don't put too much of the lubricant. So whatever is in that particular tube, you can squeeze it into the urethra and allow about 1 or 2 minutes. Gently massage the urethra. Wait for about 2 minutes for the local anesthesia to act before you actually can put the catheter in. And avoid using excessive pressure when there is a resistance. And then you have, for insertion, a very good resource, which we will also share with you. This is the AHRQ urinary catheter insertion checklist. So it will ensure that you follow an aseptic technique. It tells you how to choose the appropriate catheter, and it leads to enhanced patient safety. It's quite an extensive checklist, but whenever there is a catheterization taking place in your hospital, if you can use this checklist, then definitely the complications rate will go down. So I'm not going to go into detail, but as you can see, it starts before catheter insertion, during insertion, and after insertion. What is that you have to do, including what you need to document. Everything is there, and we will share this resource with the handout we are going to give you today. The next is failure to ensure proper placement. So insertion to a wrong anatomical structure can happen quite frequently in females because the vaginal opening is quite close to the urethra. So you need to be familiar with the relevant anatomy, get good lighting, position the patient properly, and then insert the catheter. And then confirm the urine flow before inflating the balloon. Never inflate the balloon without checking for the urine flow. And then if you have made two attempts and you are unable to pass it directly into the urethra, then you need to use a new catheter. You need to open the pack, sterile pack, and take it. Otherwise the contamination which happened while you put in the wrong anatomical structure will lead to UTI. So maximum 2 attempts, and then you have to throw the catheter and take a new one. So lack of patient communication, this is very important. You need to tell the patient what you're going to do, what they have to expect, and failure to inform or prepare the patient is what's the problem. In SkillsForMED, we have developed this greet tool where it comes in the communication module. So basically, you greet the patient, you relate to the patient, you say how are you, and relate to the attenders also, and tell them what you're going to do. Then you inquire about the patient, any particular problems they have, and what are the symptoms. Then explain. Explain is before the procedure, during the procedure, after the procedure. Step by step, as you keep doing the procedure, you have to explain to the patient, prepare them before you actually carry out the step. And finally, thank the patient and then finish the communication. So that's about insertion. So insertion, as I said, there's infection, there is trauma, and improper placement. And we looked at what are the causes of these and how we can avoid them. So the next we're getting into maintaining the catheter. So once you put the urinary catheter, then again this can lead to, maintenance itself can lead to urethral injury or trauma. Then there can be bladder spasms or discomfort, and there can also be infection during the maintenance period. So again, we start with improper hygiene practices. So when you maintain the catheter, whenever you're attending to the care of the catheter, you need to make sure you perform hand hygiene and you wear a glove. Clean glove is enough, actually. Then inadequate cleaning of the catheter site. So the place where the catheter enters the body, it needs to be kept clean. So every day cleaning it with the saline, so gauze is enough. You don't need to put antiseptics in that area. And also you have to maintain the drainage bag very carefully. So usually the emptying of the drainage bag is delegated to the housekeeping staff. So proper training has to be given about how to maintain the drainage bag, how to keep the closed system always there. So you don't know, you have to sort of do some training for this. So clean the incision site with soap and water. Very rarely use antiseptic, and do not touch the tubing or port with unclean hands. So always do hand hygiene, wear clean gloves, and then touch the tubing. Then drainage system. So as you know, the urinary catheter system is a closed drainage system, and you should never interrupt this. So many times while collecting sample for urine culture and sensitivity, when a patient has got a catheter, they will open the disconnect the drainage tube from the catheter and then collect the urine. This is not a good practice. That means you have the closed system has become now open and the CAUTI rate will go up. So it's very important to keep the closed system in place. So two ways you can collect the sample. First is by using a side port. Many urine bags come with a side port, and it is freely available here in our country, because it's only a matter of asking your supplier to supply urine bags with side port. So it is the same cost. This is something which I learned in our hospital. They were not using the side port, saying that the side port bags are expensive. Then we contacted the distributor and found out actually there is no difference in price between the drainage system with a side port or without a side port. So please use a drainage system with a side port. That is the safest way to collect urine sample, because all you have to do is disinfect the side port with an alcohol swab for 15 seconds, leave it, allow it to dry, and then use a syringe without a needle, and you can collect the urine from the drainage system after clamping it for about 10 minutes and immediately declamping it. If you don't have the side port, then you clean the urine lumen, the catheter lumen, with betadine or chlorhexidine, allow it to dry, and then use a Z technique with a very fine needle to collect the urine. And that will get sealed. Okay, so that's a slightly less effective method to prevent CAUTI than the side port, but it is better than disconnecting the catheter from the drainage tube. So closed system is very important. Always keep the drainage bag below the bladder level. Never raise it above the level of the patient's body. Empty the bag when it is about half or 2/3 full. Don't allow it to become very full. Then it leaks, and then the closed system is gone, and the heavy bag will also pull on the patient and cause discomfort. So very important to empty the bag regularly. And you can see here, the tube wing should be straight down, vertical. If you put like this, not this actual pictures, when you put like this, it forms a dependent loop and the urine stagnates here. Stagnant urine is a culture medium for organisms, and then they will ascend up and cause UTI. So always this loop you should avoid when hanging the bag. You should fix the tubing in such a way it is forming a vertical thing along outside the bed, and the urine can drain directly into the bag. Prolonged catheter without review. This is the worst form of no offense, where you put a catheter and forgotten about it. So you need to review the urinary catheter need every day, and promptly remove it when it is no longer required. So lack of regular assessment is a problem. And then lack of monitoring complications. So if always keep looking for infections, look for any blockage of the system or leakage. So monitor of infection, check the tubing for kinks, assess urine output and the color of the urine regularly. Then incorrect securement. You may think that's a very simple thing, but this is another reason for trauma at the tip of the urethra causing strictures and also ascending infection. Poor fixation also causes discomfort to the patient. So very important to secure the catheter, and this catheter should be secured. Now you put a broad micropore on the thigh as it's shown here. Place the catheter where it is being connected to the drainage tube here, and then put another micropore on top to secure it. Leave the port, the inflation port, separate. You should not tape it along with the catheter, because when you want to remove it, you can do this and then remove the tape. So this will prevent tension on the urethra, injury, and also ascending infection. So here is a video. So clean the area with alcohol, swab, and then allowing it to dry. Wait for 30 seconds, and then place a broad tape. Here they're showing small tape, but actually, we will put a 3-inch or a 4-inch tape, and then fix it at the place where it is not flexible, where it is stiff, and leave the syringe port free. So this is how you should secure the catheter. And also see there is a free loop from the urethra to this place, so that even when the patient moves the leg or something, it doesn't pull. So you should make it comfortable for the patient. And patient and caregiver education is very important, and lack of understanding on the part of the patient is another reason for complications. So clear instructions. If they're going home, give them a pamphlet about the catheter care, inform them about the signs of infection, and ask the patient to seek any help if required. So that's about maintenance and removing the urinary catheter. So improper removal technique. So not deflating the balloon, and you are using excessive device. If you don't come out, you keep tugging it and pulling it, the inner lining of the urethra will get pulled along with the catheter. That's and there will be severe bleeding after that. So very important to fully deflate the balloon with the syringe before removal and ensuring it is fully deflated. Then use a gentle movement to withdraw in a slow, continuous, controlled motion, not jerking it out. So that is very important. And then lack of communication about removal is also another thing which can cause patient discomfort and anxiety. So explain, encourage them to take deep breaths, keep that area relaxed so that they can take it out without much of pain. And many times, sometimes, you have a doubt that whether the catheter has get torn. You will see the balloon, certain segments of the balloon missing, or even the tip of the catheter sometimes can be missing. So it is mainly because, as I said, incomplete deflation and balloon damage. So verify, first of all, full deflation. And if you have doubt, you have to use an ultrasound and see whether there's any catheter fragments you can visualize. If you have very strong suspicion, even a flexible cystoscopy is required to see whether there's any fragments left behind. So that's about retained balloon fragments. So many times you find the balloon does not deflate. So what is the safest way to deflate the balloon if it is not deflating when you put your syringe to it? So you can actually inject a few more ml. See, mostly one of the things, again, a point I wanted to make is not to inflate the balloon fully. No, it will say capacity 30 ml. It is not necessary to put all the 30 ml into the balloon. That's the maximum capacity of the balloon. And this causes irritation in the trigone, and the patient gets a lot of symptoms if you inflate the balloon fully. So you need to put only about 10 ml or 15 ml into the balloon. So patient is quite comfortable with that, and it is enough to prevent the slippage of the catheter. And then you have extra some amount of space in the balloon in such problems. So you can take 5 ml and inject the saline into the valve, and this will flush out any debris or anything which is there, and then you will be able to withdraw the saline out again. If this does not work, cut the inflation port. You can cut it here. When you cut it here, it is beyond the valve, and slowly the water will, sometimes the valve may be faulty. So to bypass the valve, if you cut it here, then the water or saline will leak out of the balloon and you can pull it. If even this is not possible, then you can insert a ureteric catheter still into the inflation channel. To this, very fine, ureteric catheter can be inserted into the insertion port, that is the inflation channel port, and then you can burst the catheter. This is best done under ultrasound guidance. Okay. Even if this is not possible, then the only option is doing a transabdominal ultrasound and then using a long fine needle, usually a spinal needle which is very fine, 24 size, and then you can puncture the balloon from outside. So all these are methods and has to be done by an expert who knows about the urologist preferably. If you're going to put a needle into the bladder, or you use a ureteric catheter which may potentially injure the bladder. So, and also make sure that you will not pull the bladder into the urethra. So before this, it has to be done. Inadequate monitoring post removal. After removal, you need to keep the patient for some time and monitor for urinary retention, any pain, and tell the patients that if they get any fever within the next 2 days, to report that to you promptly. And then it could be due to contaminated equipment. So you take the removal very casually. So any syringe which is lying around in the bed, you can if you take it and use it, that can cause infection. So use always sterile needles to deflate the balloon. Dispose the used equipment as per infection control guidelines. Otherwise, this can contaminate from patient to patient. Also, there are certain patient-specific considerations, like patient may have strictures or they may have had surgery in that area. So more prone for retention after removal. So these patients must be monitored for a longer period of time. A void chart should be maintained. So the minimum volume should be around 300 to 400. That means they are passing urine without any retention. If they are passing urine which is only 50 or 100 ml, and very frequently, every half an hour, 1 hour, they're passing urine, but they only avoiding 50 ml or 100 ml, then it means they are in retention, and then you need to do a ultrasound to see whether they have a distended bladder. So these are very important things to consider, especially in patients with specific considerations. So we have to talk about CAUTI because we are talking about, next we're going to talk about catheter bundle, CAUTI bundle. So the incidence of CAUTI is 4.1 in high-income countries and double in low-income countries, mainly because we keep telling we have low resource and therefore cut corners. But the real truth is we don't follow scientific guidelines and the evidence, whereas the high-income countries are doing that. So if you follow the guidelines in the bundle, then definitely you can prevent the incidence of CAUTI. So all of you know that a bundle is a set of evidence-based practices or interventions, and when implemented together, improve the outcome for the patients. Okay? So there is proof to show that each element of the bundle adds to the reduction of complications. If you use only 4 in a bundle, it will reduce the complications by about 1/3. If you use 12 in a bundle, it will reduce it by almost 3 times that much. Okay, so it's very important that all these catheter placement, catheter care, catheter removal, and if at all you have to reinsert, you've got to talk about, you have to have a bundle list for that. So in the CAUTI bundle, we have insertion bundle and then maintenance bundle. So here is the big checklist. So here you have insertion. We talk about aseptic technique, appropriate catheter, proper insertion. Okay. So this is the insertion bundle. And in maintenance, daily review, closed drainage system, regular hygiene, positioning of the drainage bag, staff education, patient and family education. We covered all this in our talk. Okay. And the removal, proper removal technique and monitoring post removal. So if you now use this bundle and checklist and make sure every patient in the case sheet you keep the bundle. At the time of insertion, you check this. During maintenance, every day you check this. And at removal also you check this. Definitely your CAUTI rate will come down. Okay, so these are two important resources which we'll be happy to share. And I think that brings us to the end of this webinar. So I've summarized all that I have spoken in this webinar in 10 best practices. So assess the necessity. Put a catheter only when indicated. And the care bundle will give you those indications. And if it is not for that indications, do not put the catheter inside. So prevention is the best form of, not putting the catheter is the best form of prevention. Next is, if at all you have to insert, use aseptic precautions. I told you it is a sterile procedure. You need to respect that and use all sterile precautions. Choose the right catheter, the right size and the right type. For normal use, latex is enough. If the patient is going to have long-term use a Teflon coated catheter. Then proper insertion techniques, we went through that in detail. Maintain proper perineal hygiene. Now, this is very, very important. Manage the drainage system. No, don't make it the dependent loop. Don't hang it too low or don't raise it above the level of the bed. Monitor for complications as long as the catheter is in place. Educate the patients and caregivers. Secure the catheter properly and follow CAUTI bundle guidelines. Remove the catheter the moment it is not necessary. Don't keep it even for an hour longer. Don't say, okay, catheter is not necessary, it is end of the day, let's take it tomorrow. Sometimes if you have no low nursing staffing, it may be better to remove it in the mornings. But otherwise, review for catheter indications on a daily basis. Thank you so much for your attention and joining in such large numbers. Thank you so much. Thank you.